All right, good morning, everyone. This is the panel on surveillance, which we've all been looking forward to. I'm not going to introduce the panelists to you. Their bios, their biographical information is in your materials. They're going to be speaking in the following order. This is Nate Wessler, immediately to my right. Kalia Hamlin at the end will go second, and Paul Hattis will be third. Just to tell you briefly where they are from, as I say, I'm not going to give you their biographies. Nate Wessler is at the ACLU. Kalia Hamlin is with the Personal Data Ecosystem Consortium, and Paul Hattis is at Tufts University Medical School. I want to talk briefly about why we have this panel. Why is medical data important? I was at the OECD in Paris, which has, at that point, had 25 member countries. It's an international organization, a treaty organization, the most developed countries in the world. Now there are about 30 members. And one of my jobs was to look after privacy. There were a number of privacy international accords and national legislation by that point. So we had meetings every year on privacy, and I would choose a different subject and cut at it. And so in the early 1990s, either 1990 or 1991, I chose the subject of medical privacy, now more often called health privacy or health information privacy. At that point, it was called privacy of medical data. And we chose that as a subject. And so quite typically at the OECD, we would ask member governments if they had any, well, we would produce documents, we would write reports, the Secretariat, and then we would ask member countries if they wished to submit what were called room documents. And so those were submissions, informational submissions or whatever from member governments. And with a controversial topic, you might get 2 room documents. So very rarely, once in a while, you would get a room document or 2 from one of these 25 countries. So for the medical privacy meeting, I sent out a request and said, would anyone like to submit any room documents? And we had 35 room documents. 35 room documents came in, and it revealed to one another this incredible wealth of activity that had already been taking place for decades with regard to the computerization of medical records. So starting in the 1970s, and this was in 1990 or 1991, the huge amount of research and thought that had already gone on in the OECD member countries to protect medical records and within their computerization. So we had many, many examples of that. This is not an old issue, a new issue, this is an old issue. And why is medical data important? So it's obviously of importance, and you all come to it from different perspectives. But I'm going to speak just from my perspective for a minute, where I come from and thinking about medical data. Medical data or health information is a massive load of highly sensitive personal data. That's what makes it so interesting from a privacy perspective. And it's a very hard technological problem in that sense, although it has become increasingly simple as a technological problem over these recent decades. So it's similar in that way to money or voting. Those are also some of the more difficult or have been the more complicated technological problems. And if we can sort out how to protect health information, how to do online voting, how to have digital money that's robust, then we've solved a lot of other problems in the ubiquitous information environment and in the exchange of information. So that's why one of the reasons we're talking about medical data today. I want to remind you of, as we're going to enter into this discussion about surveillance in particular, of a few of the basics with regard to protection of personal data and information. There are 2 big axes that underline the entire field, and they are that the individual, in my view, must control and own her personal information. And there are places on Earth where that is done today, although not in the United States. The second grand strut that underlies this whole area is that of proportionality. In other words, that the solution that's developed be in some way proportional to the harm or the problem you're trying to address. Because also if we tend to over-solve or create over-solutions, then you start to create additional vulnerabilities. Some of the basic concepts of data protection and privacy are notice, that the individual be given notice. And it was very interesting to me yesterday morning in the discussion, one of the speakers yesterday was saying, well, notices are so lousy, notice doesn't work, we shouldn't have notice anymore. That's not the problem. The problem is we should have notice, but we need to be much more effective in the notice we give. So there's notice, individual choice, and individual consent. When information is collected, the purpose must be identified. Only the information for the identified purpose should be collected, and only that information which was collected for the identified purpose should be used. No fishing expeditions, no secondary or tertiary uses. These are basic concepts that are well accepted throughout the world. So I wanted to remind you as we're starting that discussion today. Now, moving specifically to surveillance in the ubiquitous information environment, I'm going to turn it over to these speakers who are ready to go in just a moment. Surveillance is pervasive. I like to talk about the ubiquitous information environment. So what is that? That's a pervasive information. So computing will be going on in the air you breathe. This will be a computing device. Liquids in the air you'll be breathing in and out. Computing activity, some of which will reside within you, some of which will move out and move somewhere else or whatever. Others will be able to monitor your internal states, as happens already, and it'll be communicated elsewhere. So in terms of the granularity of information collection, including about your physical or mental health state, it's going to just increase. Right now, already, the NSA has, in addition to all the other things that we are all reading about and that you're going to hear about, they have what they call a social graph. They have mapped all relationships in the world. This is trivial to them. And this exists today. And I urge you to go look up Bill Binney's name, William Binney, who was a senior official at the National Security Agency, and there are plenty of YouTube videos of him talking about this. So these are the kinds of, this is the environment we're in, one where all social relationships in the world not only have been graphed, are being real-time, continuously graphed, continuously monitored, so that all of your relationships are known. And we have an environment where computing is literally everywhere. So with that in mind, I'd like to turn it over to to Nate Wessler, please.
Thank you. And thanks for the chance to speak today. In my work at the ACLU, I'm largely concerned with regulation of law enforcement access to sensitive data, which is what I'm going to talk about today. And I want to talk in particular, to start out, about law enforcement access to state prescription drug monitoring programs. 49 states have these databases. Missouri is the outlier, and they track information about controlled substances prescriptions issued by a pharmacy to a patient. So that's drugs that are on the federal controlled substances list, which range from opioid painkillers to Xanax to Ambien, testosterone, Tylenol with codeine. And so every time in these states, every time a patient fills a prescription from a pharmacy, the pharmacies are required to electronically report personally identifiable information about the patient tied to information about the drug they received, dosage, refill information, et cetera. And it resides in state-controlled databases. Now, this audience, you all know well that knowing information about a person's prescriptions can reveal a whole lot about their underlying medical conditions, and that can be very sensitive information and very private, and strict controls, I think we all agree, are important. Now, there's certainly a public health use for these databases, these PDMPs. Doctors, for example, can look up a patient's prescription history and see whether they have been doctor shopping for an addictive drug or whether they have other concerning prescription history. But law enforcement is also interested in access to these databases in order to investigate doctors who they think may be illegally prescribing certain of these controlled substances, or patients who they think are fraudulently obtaining them. But law enforcement access, when it's not adequately regulated, raises a couple of concerns. One is a policy concern that it can end up deterring patients from seeking care. But the other is a concern under the Fourth Amendment to the U.S. Constitution, which protects the privacy of this kind of very sensitive data and requires police to get a warrant from a neutral judge based on probable cause when they want to access this kind of information in an investigation. States vary widely in what kind of protections against law enforcement access they impose as a matter of state law. So 10 states require, as a matter of state law, require law enforcement to go to a judge and get a warrant or to otherwise demonstrate probable cause. There are a number of states in sort of a middle zone that either require a court order on a lower standard like reasonable suspicion or just a subpoena. And there are a number of states that let law enforcement directly log in to these databases or request access without any kind of legal process whatsoever. And I want to just finish my introductory moment here by talking about one case in Utah that we've been involved in that really beautifully and tragically illustrates the danger of poorly regulated law enforcement access to these databases of this information. The Unified Fire Authority is a large unified fire and rescue district surrounding Salt Lake City. A number of towns and cities are part of it. It has a dozen or maybe 14 fire and rescue stations with a bunch of ambulances. And they discovered that several vials of morphine had been tampered with in a couple of the ambulances, and the morphine had been drained out and saline had been put back in. So they called the police to try to figure out whether it was one of their employees who'd done it, maybe a patient who'd gotten access, what had happened. Police weren't able to figure out who might be a likely suspect through traditional investigative techniques. And so one of the local police departments, a local cop, decided that the next thing he would do would be to directly log in to the Utah Prescription Drug Monitoring Program, which under Utah law enforcement can do without going through any kind of legal process. And he downloaded the prescription histories of every single one of the 480 employees of the Unified Fire District, 480, without an attempt to even narrow down to who had worked in the firehouses where these ambulances were or anything. And he looked through, I guess, for a history that suggested that they had an addiction to an opioid painkiller that might have suggested that they had taken this morphine. He couldn't find anything sufficient to make that linkage, but he didn't stop there. He decided that he wanted to sort through these records a little more and see if there's anything suspicious enough to bring charges against someone for something. And so he continued to just look through all these records and identified 3 firefighters and paramedics whose prescription histories he thought were suspicious enough to try to bring charges, and he was able to convince a prosecutor as to 3 of them. We got involved on behalf of one of these paramedics, raising these Fourth Amendment arguments about how this search was illegal. And the evidence that they were able to get kind of illustrates the ridiculousness and the danger of this kind of access. He had gotten a painkiller prescription from his general practitioner for, I think, a work-related injury. He had then subsequently had oral surgery, and the oral surgeon had given him a post-operative prescription for another painkiller. Neither doctor thought it was a problem that the other doctor had prescribed, but this police officer thought he knew best, and so convinced the local prosecutor that this paramedic was fraudulently obtaining narcotic prescriptions, and they've now brought charges against him. And so he has suffered not only the indignity of an illegal search, but he now is mired in probably years worth of criminal defense to try to get himself out of this mess. And we're doing what we can, and he has good defense attorneys, but it really has turned his life upside down. So I'll stop there for the moment. There are other cases elsewhere in the country. There's a case we recently won in Oregon about whether the DEA can access a state prescription drug monitoring program without a warrant, even when state law requires a warrant. And I'm happy to talk about that later, but I think these are pressing issues, and they really go to the privacy interests that we're all here to talk about.
Fabulous. Thank you very much, Nate. Kalia.
Actually, I wanted to put up a couple slides, so whoever was bringing me a USB key.
Do you have a flash drive?
I do. Well, no, I don't. I need a flash drive to put it on the system, right? Okay, thanks. So what I wanted to put up, and hopefully we'll get it set up, is there's a real problem with the frame that I think we're in. We're in a frame that's anchored in 1973 when the original FIPS were articulated, and we need to get out of that frame and get into the present that we're in. And I think we need to well, I'm supportive of all the efforts to sort of work on notice and consent and informing consumers of what they're doing. We also need to start talking about our rights to data, and that it's very clear that different entities that transact with us will have copies of data about those transactions. And right now, there's so much information asymmetry between us and them that's an issue we need to be addressing. In 1973, none of us had computers in our homes. 10 years ago, almost none of us had computers in our pockets, and now we do. But when we go and we buy a coffee at Starbucks or interact with our doctors, we get, at most, a piece of paper. We don't get an equivalent electronic version that helps us build up our own profile of who we are and our own data footprint. And so I think, part of what we have to do is talk about data rights and data responsibilities, and also consider the anchor that we're which part of the law are we anchoring the conversations in? If we continue to anchor them in property law, we're anchoring them in a world of atoms. Either he has this water bottle or I have this water bottle. And in the digital world, we both can have copies of the same data, and it doesn't infringe on one or other of our rights or our ability to have it. And so I think that, in getting to how we sort of address issues of surveillance, we don't have the capacity, or we're not being given the rights to our own data as we move about the world, so we can sort of surveil ourselves and take back power and then manage how other people see us. So those are my comments, and I'll put up the FIPS in a minute, hopefully.
Okay, great. Thank you very much, Kalia. Paul.
So I guess hearing Nate initially talk about legitimately the concern about people like law enforcement getting our individual information they shouldn't, and Kalia talking about how do we get the information that we don't currently have, both also a very legitimate concern. I guess I worry about both sides of those things, but let me tell you how I'm coming at this. Although I'm listed as a Tufts University professor, which I am, and in public health and public policy, I wear a couple other hats that I come to thinking about this conversation. One of those hats prevented me from coming yesterday. I'm one of the initial founding commissioners on the Massachusetts Health Policy Commission, the Stu Altman chaired commission that our state and healthcare reform 2.0. We did the access bill in 2006, 2012. We did a cost containment bill, and our commission is empowered to do certain things under the guise of, or the desire to control the growth of healthcare costs. And so I think about some of these issues in front of us today from that perspective. But the main reason I'm here, and Andy Oram and I share, is that we're part of a consumer organization called the Greater Boston Interfaith Organization. I mean, we're sort of lay members, and in fact, the members of our only congregations, primarily churches, synagogues, a mosque, a couple labor union groups, and community development corporation organizations, who works on social justice issues, although GBIO has spent a good deal of time over the last 10 years working on healthcare, and really its involvement with that organization, where we've been talking about what is it that consumers want in a socially just way about the healthcare system that sort of guide what I want to share with you. So in one of those conversations, we at GBIO over the last 8-9 years have said, when it comes to the healthcare system, it's our money. It's not theirs. All the stakeholders out there think that it's, doctors, hospitals, insurers, it's their money. It's really not. It's ours. It's our information, and it's our community responsibility. And I see what I'm chatting with you about here briefly, and then we'll hear from our whole panel is the our information part. So in GBIO, again, these are not IT professionals, although they include that, like Andy. They're not all healthcare providers, and I sort of come a little bit from that realm. It's a broad array of folks sitting around a table trying to work on social justice. But we did talk about, I'll sort of name some of the issues we did talk about in this one discussion, which is emblematic of maybe both sides here of what Nate and Kalia gave you. We talked about having control over our own personal health information and who gets access to it. And here I'm talking, I guess, really primarily in the identified information realm. 2, we want an ability to place that information in a secure place, probably on the web. For many of us, we can talk about why that's probably important. And although I put initially ask, maybe I should say require providers and others who have that relevant information to send it to that place that we designate so it's available for us to control. We, the consumer, ought to be able to share that information with providers and be able to do so when we choose, even selectively as to what we share. Although I say this with my physician hat on, that can be complicated. People's care might be for the worse because they're not sharing information, although that's always been an issue, in terms of what people are willing to share. The cost containment role I said Health Policy Commission is that we might, by not sharing information or decide to do it selectively, cost us all have to pay more in our premiums potentially, so that it's not only affecting the individual. Maybe we can come back to that. Another hope is we want an effective EHR, electronic health information system, that respects our wishes and our desire to maintain privacy. In Massachusetts, we're pushing not only all the hospitals to be on the e-highway, but physicians connected to those hospitals. And, you know, and maybe this speaks wonders about where our Health Policy Commission is in, which is we have not yet had a discussion from a policy perspective about the issues that we're talking about here today, in terms of, you know, really worrying that much, at least on our radar screen, about issues of privacy and the like. But, you know, those doctors that are hooking up, and we worry about, you know, what kinds of protections they have, and, you know, the ability to exploit somebody's information system and do medical identity theft, or to do something else that, you know, is potentially not in our interest. I think we would worry about, and we worry about those EHR systems. We also worry about that those EHR systems are proprietary. So, you know, I get cared for today in hospital system A, and, you know, there's huge battles going on in Boston over, you know, patients and money and all that, but I cared for at hospital system A. But tomorrow I'm presenting in front of a doctor from hospital system B. That information isn't going to move from hospital system A to hospital system B, even though they both have electronic health informations. And in fact, hospital system A might not want to lose us as a patient and lose that global payment, and want to make it difficult to move information from A to somewhere else. So we'll, you know, have to stay with them as opposed to bring our capitated payment elsewhere. You know, at least that's in theory a worry. I guess I could go more. There's some other issues, but let me end with our own story, though. In the Globe earlier this week, and, you know, and this talks to the issue, I guess, about having access to information, was an opinion piece by a gentleman who right now, because he got exposed to measles, and he's being quarantined, and he's been trying to get, he's probably, I think, in his early 40s, to get a paper record from his mother or some other place that shows that he was actually vaccinated years ago, so that he can't, you know, he's protected against measles. Well, that piece of paper can't be found, so right now he's under quarantine because there's no way of proving that since he's been exposed, he could get the illness and then ultimately, you know, pass it on to others cause a measles outbreak. So the point is if that information, you know, the net didn't exist, or the web didn't exist 30, 40 years ago, but if today somebody gets vaccinated, becomes part of your permanent record, he wouldn't be quarantined right now. So, you know, there's other aspects of ACOs and de-identified data, and the alcohol drug abuse patient record issue not touched fairly since '87, and the discrimination legal consequence issues, which I'd like to talk about, but let's get into that from questions. Otherwise, I don't want to monopolize our initial discussion here. Thanks.
Okay, excellent. Thank you very much, Paul. Thanks to all of the panelists. I asked them to speak for 5 minutes each so we could bring you into the conversation as early as possible. So I'd like to open it up for questions. Please line up at the mics if you'd like to ask questions or make comments. I'd like to just, while people are coming up to the mics, I'd like to ask you about genetic information, you know, because that also has the additional element. Oh, and first of all, let me remind you, all of you, that this conversation today about surveillance of health data is taking place exactly 1 year, June 5th, from the first information that the public was receiving about the materials that Edward Snowden had taken from the NSA. So it was actually in the Washington Post and the Guardian and so forth. It was 1 year ago today that all of that was happening. So very timely. Let me ask you, though, about genetic. I want to widen this conversation a little bit right away about genetic information, because that also implicates third parties, you know, who aren't the direct patient. Comments or on that? Perspectives on that in terms of the surveillance implications? Because there you could have a situation where an individual patient may or may not know that they're, you know, being treated, or that their records are being looked at. But with genetic information, you're obviously implicating, you know, anyone genetically related to them. Any comments on that?
So you're saying that it's not only being able to analyze somebody's genome and predict future health issues, which could cause discrimination or legal consequences in some way, by saying that if my genome is read, it has implications about others that are biologically related to my genome, that I'm giving, in some ways, disclosing things about them as well.
Absolutely.
Yeah. You guys want to comment?
I mean, I approach.
Thanks for clarifying, Paul.
I've named the problem, so.
I approach all these questions from the perspective of, you know, what should law enforcement be able to obtain and when and how. You know, I think with genetics, there's a question about, you know, direct collection, coerced or mandated collection by law enforcement, for example, in a criminal investigation where they're trying to match a DNA profile to evidence at a crime scene. whether they should be able to collect samples from suspects and on what level of suspicion. Do they need a warrant or just reasonable suspicion? And then a question of access to databases of genetic information held by government entities, private entities, the sort of 23andMe companies that now are holding probably a whole lot of deeply private genetic information about a lot of people that may not have turned out to be that useful diagnostically, but certainly can be pretty intrusive. And so there are yet not good answers, and the courts have just barely started to wade into this area.
So what comes to mind is a kind of creepy use case that I heard about at South by South, or I heard was discussed at South by Southwest, which is marketing companies going in and sort of swabbing products in stores to figure out who was touching them by analyzing the genetics that were left behind. So not necessarily the specific people, but figuring out which people from which ethnic groups were interested in what products. So, as soon as you touch sort of genomics, which is in all of the skin we leave behind everywhere, like these things, all biometrics, most biometrics are not secret, right? So we share them all the time. There are my fingerprints. Look at my eyes, right? So I think they're misunderstood in terms of how we have conversations about how we manage them and how we protect our, what are the rules? And we're not having a clear conversation about them because we keep thinking they're sort of secret and ours, and they're not.
No, in fact, we're all shedding DNA all over the room, right? Adrian.
Paul, this is an opportunity to actually, and a very appropriate to this panel, firsthand experience with respect to surveillance of healthcare data. And I'm very glad to see Paul on the panel. Relative to Kalia's comment, there is in Massachusetts an all-payer claims database, which is one of the 3 government-mandated councils or aspects.
Our Health Policy Commission is trying to, we hope to learn a lot from that database. So.
And when that law in 2012 was being put, I put in, with the help of my congressman, a clause that patients would have access to the information about them in the all-payer claims database, in this surveillance entity. About a year ago, while this thing was now operational, I went and spoke to the person running the all-payer claims database, and because they had not put in the patient access provision of the thing. And I was shocked because for the first time in my life, actually, they had the general counsel in there at an initial meeting. This was a big deal, interesting for me. And the answer was basically, the reason we did not put in this feature that's in the law is because it's too hard.
And saying it's not an issue, it's not an implementation rollout issue. They're saying it's never going to be, to their perspective, it's not going to be made available to all ever at this point.
I don't want to take the whole time here. I'm happy to go into the specific details. We have a legal scholar and the
Right. So
I can go into the details. I'm just trying to basically pose the question that when it comes to surveillance and fair information practice, where you have government acting to do surveillance in healthcare, and ignoring even the most elementary aspect of fair information practice, namely transparency, when specifically listed by law, what we end up with is that people pick and choose the council. And I tried to speak to the person who runs your part of the operation. They didn't even want to speak to me. I'm forgetting his name. So what does this say from a ACLU perspective about how these things are governed when they relate to healthcare, how they're implemented when, as you are, and I'm sure you're on the right side of this, but what is the limitation from your perspective as a trustee of this process? That's my question.
Okay. Did you want to take the?
No, go ahead.
Well, the part that I'll say is, because I'm fighting my own battles about if it's in the law, then we ought to have it implemented. So, I will leave that, the specifics of that, and maybe you and I can connect around that afterwards. But it raises the general question, which is, I do think that, and the law, whether the law says it or not, but in this case, especially where the law says it, if individuals have a right to that surveillance information, and are you trying to get at it from the perspective of a person has a right to get at it as a researcher, get at it as my data sitting in the database? So
that was the executive director. First question, and the reason I want it is because Massachusetts has a health insurance exchange for many years,
right.
And the information in the all-payer claims database would allow people to choose which plan, to know retrospectively what their out-of-pocket expenses would be. Right. The software that would be required, whether the state provided it or my accountant provider, would be trivial for me to see the 30 choices in the health insurance exchange and what would have been my out-of-pocket cost for each of them, so that at the re-sign-up time, people could save a few $100. And I've written about this in the healthcare, in the BUR on the radio station blog, as to how I could extrapolate savings of hundreds of dollars per enrollee if they could pick based on the information in the all-payer claims database. So this is not.
Let me broaden your question, and maybe Nate wants to make a comment, which is, I think identified data versus de-identified data, we are in two different lands there, okay? And I do think, though, if you're saying, should you as an individual have access to the same de-identified data that health plans and hospitals or others have to try to make decisions around, I would say we, as individuals, we ought to be empowered.
There's nothing de-identified about data in the all-payer claims database. The whole point of it is that they're aggregating information from all of the places where people are spending money. And the law and the purpose of the database is, there's nothing de-identified. I'm not talking about research uses. I'm saying the clause is what Kalia said. It is, can I have symmetry so that if I have my own software or my own accountant that I acting as my agent, can I save those $500, $600, $800 a year, maybe thousands in some cases, by the benefit of the surveillance that's being done under the law?
Right, but the surveillance under the law, just to understand what your point is that you're saying you ought to be able to access that database with identifiers in it.
He wants his own data.
Oh, just your own data out of it.
Pardon?
You want your own individualized data. You want to be able to make a data request to say, I'm Nate so-and-so, here's my social security number, somewhere
Maybe
in
you
the
should put up the fair information practice at this point.
Yeah, okay, all right. So I'm going to think about that, but I don't see why not. In other words, if it's available to you and the law requires it, you ought to be able to get it. It seems that's a straightforward question. So.
Any comment, Nate?
That seems to sum it up. I think there's, with any government function, there's an important value of transparency. And when we're talking about our own data, there's a particularly compelling reason to have access to that, as long as all the other protections on privacy are unaffected by that.
So
and while Clea's put up a slide, maybe more efficient than having to ask every, as you say, provider to upload information. You can get it all from the all-payer claims database in one request. Why not?
So, it does seem appropriate to pull this up and share it with you.
Can you lower the house lights?
A little bit, because they're really good words. So I came across this paper, and it's referenced on the slide before, called A History of FIPS. And what's great is reading these 1974 principles, because it says there shall be no personal data record-keeping system whose very existence is secret. And this language about personal data record-keeping systems is abandoned in all subsequent versions of this. And so the fact that we're talking about these systems kind of gets lost and abstracted as we go through time. And I totally invite you to go and look through them, but so they changed, right? And then we get the OECD principles, which just start referencing personal data. and stop talking about record-keeping systems. And then the Federal Trade Commission recommended these principles for commercial websites. So there's only 4 that they pulled out. And then the DHS version of FIPS sort of keeps changing more, focusing on PII, personally identifiable information. And then the NSTIC put forward a set of FIPS, the National Strategy for Trusted Identities in Cyberspace. Jeremy was here yesterday speaking to us, and both myself and Adrian are on the Management Council. They watered them down. So they're not current, and they don't they don't come from a place of where technology is today and where it's going. And I think we need to, I've been talking about a term to regulate forward. So we look ahead to where technology is going, which is what you're talking about, and where is personal health tracking going? We put these forward to think about principles for a personal data ecosystem where people are collecting and managing their own data as well. And that the word and term I really like to focus on is dignity. And also this other piece, respecting relationships. We're talking about relationships between patients and their doctors in this context a lot, and patients and the people paying for care and the people they work for. And we need to understand these systems and make them work for those relationships. And then these are just some of the last ones. So I'll give these slides to Deb, and you can have them up on the website. So.
Thank you, Kalia. Next question.
This is for Nathan. In addition to the prescription drug monitoring databases that states have, I gather many of them have quite elaborate public health surveillance databases too, clocking who's been vaccinated and who hasn't, AIDS status, sexually transmitted diseases, all kinds of other things. And that some states and cities are even using these not just passively but actively to contact citizens whose A1C scores are too high. And has the ACLU brought any cases or any concern about those, or is anything that's done in the name of public health fair game?
So I'm not aware of any work that we've done directly on those, although we have 50 state affiliates and some of them may well have done work on a local or state level. I do think that the purpose of collection and the protections put on the data matter in these contexts. And so, I think there's properly some more latitude around public health efforts than there is around law enforcement access for punitive reasons. But that doesn't mean there should be carte blanche to, collect everything and anything just because it's possible. And it matters a lot whether the data collected for a public health effort is restricted solely to that, and there's a firewall put up so that other government agencies can't access it, right? If you're there's a public health initiative to make sure that people with HIV or AIDS diagnoses are getting appropriate follow-up treatment. That's as sensitive as can be, and it's not only embarrassing, but can result in lots of kinds of discrimination. So. There may be types of information that we don't even want public health officials to have access to in that kind of a mandatory broad way. But I think it's less concerning than some of the other types of government access that we've seen.
Good. This may be a good moment. Would you take a minute and tell them about what went on in Oregon?
Yeah. So Oregon was interesting. So Oregon has a great, relatively good privacy law around its PDMP, requiring law enforcement to go to a judge and get a warrant before getting access. The DEA, though, loves these state databases and had been insisting that it had a right to access the records in the database in Oregon with a subpoena, which does not require going through a judge at all. It's just a piece of paper issued by the agency. And the DEA was saying, we're not bound by this state law. We're a federal agency. Do whatever you want in your little state, but we want these records and we want them now. And so the state of Oregon sued the DEA to figure out whether, in fact, they could rely on their state law and not give the records over. And then the ACLU intervened in that suit, representing a group of 4 patients and a doctor in Oregon who have prescription records in the database who were concerned about their personal privacy and the potential violation of their Fourth Amendment rights. And just a couple months ago, a federal judge in Oregon sided with us and said that the information about your prescription history and your medical information is about the most private information there is, and the warrant requirement of the Fourth Amendment absolutely applies. And I guess the last thing I'll say about it is that the government makes a couple of arguments to try to respond to that. The one they try to press most forcefully is, I think, the most offensive, which is that under Fourth Amendment doctrine, there's this thing called the third-party doctrine, which is the principle that if you voluntarily share information with a third party, whoever that might be, then you are deemed to have given up your privacy interest in it as to law enforcement. So this happens with phone metadata, the numbers you call, you share them with your phone company, therefore law enforcement should be able to go to the phone company and get them without a warrant. They were making this argument in the context of medical records, the mere act of going to your doctor and sharing your health information and then bringing the prescription to your pharmacist, and then your pharmacist, mandated by law, sharing it with the secure state database. The DEA was saying, waives your privacy interest in it, the Fourth Amendment shouldn't apply, which the judge rightfully just dismissed out of hand, and I think is offensive, but it's also pretty dangerous in this context.
I hope that the ACLU is taking direct aim at the third-party doctrine, which is a really extremely anomalous American concept that rose up sort of pre-information age, but is being applied now.
Yeah, I mean, we have litigation in a whole lot of areas. These kind of health records contexts, location tracking, whether your cell phone location information held by your self-service provider can be obtained without a warrant. Lots of other contexts. So it's true that the bigger the data sets about us get in this increasingly digital world, the more ability the government has to go grab very, very precise pictures of who we are, what our health is, where we've been, who our intimate partners are, et cetera. And so the doctrine is from the 1960s. It just makes, I don't think it made sense then, but it certainly makes no sense now.
Right, and so watch the Supreme Court will be issuing their decision in a case called Riley very shortly on cell phones, and it does have relations to the things we're talking about here. Please, your question.
Bill Yasnoff, Health Record Banking Alliance. Deborah, you mentioned that in other countries, people have the ability to individually control their personal information. One of the arguments we hear about that is that allowing people to do that would have all sorts of negative consequences. So naturally, the expectation would be in other countries where they do allow this, there would be all kinds of negative consequences. And I wonder what kind of consequences are actually seen in those countries that do allow people to control their personal information, whether they be positive or negative.
Well, I can imagine one, right? I mean, which my medical colleagues always argue back against me. It's 2 o'clock in the morning. You have a car accident, right? They all keep saying you're unconscious. Only you have this password protected information up on the web, and the care provider is wanting to care for you. Well, you could argue back. They don't really need to know everything about your history to know what to do once you've had head trauma, but they will make the argument. I'm not saying I necessarily support this in all respects. That to get relevant information, to best care for you can't get it.
I want to answer your
respond back to that.
To add to the answer here.
So this means in countries that allow this, there are many unnecessary deaths due to lack of information.
No, that's not the case at all. And I just want to, because we have to close this panel very shortly, but I just want to remind you, and it's on the PPR website, in the 2013 summit, last year's summit, the panel that I moderated, one of the speakers was Peter Boetsma from the Netherlands, who's actually in the audience 4 rows behind you. So please seek him out at the coffee break, and you can go back and watch that video in which he talks about the Netherlands healthcare system, which is an example of this. So that would be a good example. We have to conclude now shortly. I don't want to stand between you and your coffee break. I do want to ask each speaker to tell us, this is the final lightning round here, to tell us one thing in their estimation that could be done. So it actually is possible to be done. One thing that could be done that would most improve protection of health information from surveillance. Nate.
I think in the law enforcement context, state legislatures are our best hope in the near term, and in the PDMP context, Oregon, Rhode Island, Georgia, Arkansas, a really diverse types of states require warrants. There's no reason others can't. This is not a liberal versus conservative issue. It's health privacy appeals to people very intuitively and deeply.
Paul.
I guess I would say make sure that as we evolve our future evolving healthcare system, that the state laws or federal laws can be passed to make sure that proprietary or self-interests don't trump the interests of individuals to get the information that they need and want.
Leah.
So I would say support the emergence of this personal data banking industry that's got little sprouts happening both for medical information and other types of information. Look at what British Columbia has done in Canada. They actually have issued a combined services card for their citizens to access government services and built a triple blind system so that you can use the same card as your driver's license and your healthcare card. But because of how they've architected it literally has 3 steps and 3 totally different databases and really partitioned out the different parts of what it means to authenticate into a system and to give access to records. And that also is the key to your electronic medical record. And that as the province, they are the insurer for everybody because they have universal health care. And aspects of that model could be looked at and applied here, where you get a card and it supports you through many steps getting into your healthcare record, wherever that may be. And also, finally, another thing that they did was in building this system, they had to make choices about how it would work technically, but also policy-wise. And in order to make those choices, after they'd done the key architecture, they said, we could do more with this system. You could log into commercial websites, into many different government services, but before we extend it beyond healthcare, we need to get citizen input. And they actually brought together a panel of 36 randomly selected citizens from around the province that were representative of the diversity there, geographic, age, ethnic groups. 36 of them, they brought them together for 2 whole weekends to explain how the system worked and to ask them what their recommendations were on 5 key future policy choices.
Good. So perhaps
that was the basis of how they're doing it. And I think we need to look at those models of real citizen engagement about policies so that people trust the answers, and it's not just rooms of experts like us.
So perhaps for an action item for next year's summit is to invite Elizabeth Denham, who's the Privacy Commissioner of British Columbia, who could perhaps explain this. Please join me very much in thanking this panel this morning.
Okay, that was great. So we are running a few minutes behind schedule, but we won't take up too much. So we're going to be right back here at 11:05. We have one more panel with Dr. Peter Levin, who's going to talk even more about personal health data. So be sure to join us in about 10 minutes. 11:05. Thanks.
Yeah, the folks in Massachusetts are great.